she could understand 90% of what she says, but over the past week prior to admission, she was able to understand only about 50%. Patient did have URI symptoms 2 weeks prior to admission, but otherwise there was no recent fever, no trauma history, no known drug ingestion. So for the patient's history, she was born full term. There was no complications. And for the past medical history, she was diagnosed with acute cerebellar ataxia when she was 23 months old. And also, she has a history of hospitalization for seizure and suspected meningitis at the age of 2 years. So later, during my presentation, I am going to go into more detail about these episodes. She was not taking any medications, and for the family history, mom had history of Korea, but at the time,
Afra, your slides are not going along. It's
they're
still
not.
on the first slide. Sorry to interrupt you.
That's okay. I shared actually. Let me see. Are you able to see now or no?
No, not at this moment. Yes, we can now. At least it's on HPI screen.
Okay. So are you seeing the whole presentation or are you seeing my screen right now?
Afra, I think you have to hit play for your slides for them to show.
What about now? Does it work?
No.
Okay, even I hit the play.
Right now, the histories page is big, so if you scroll through like that, I think it'll work. If you keep, each time you switch, just click to a new slide.
Okay, I can do that way if it's okay. Okay, so as I told, mom had history of Korea, but at the time that we saw the patient, mom's symptoms, they were like more titubation-like, and she had some semi-purposeful movements rather than Korea, and she didn't have any definite diagnosis. And for the maternal grandmother, she had questionable Huntington disease. Because we don't know the details, mom was adopted, and paternal history again is not known. So for the general physical exam, it was unremarkable. There was no neurocutaneous findings. And for the neuro exam, patient was awake, alert. She was reacting to external stimuli. She was interactive. Cranial nerves, they were intact. Extraocular movements, they were complete, and we didn't see any nystagmus. For the motor exam, tone was normal, strength normal. Patient had this white-based gait. She was unable to walk without someone holding her up. And also she had significant truncal ataxia because while she was sitting on the bed, she had to hold onto the side rail to keep herself up. And also we saw these like intermittent myoclonic movements in the upper extremities. Sensory, it was intact throughout, reflexes 1+ throughout, and we couldn't check the coordination because of the patient's age. So at this point, I'm gonna ask you about the differential diagnosis that could be. Does anyone would like to come up with some differentials?
Let's get some of our pediatric residents to.
Yeah. Anyone? No.
Vestibular neuritis could be one of them because she had recent URI symptoms. Other mom's history of Korea and Huntington's disease, I think genetic testing to rule that out, although anticipation is possible, but I don't know if that it can present at this young age.
Yeah, these are good thoughts.
Cerebellar imaging for any masses or anything like that in the posterior fossa can also cause any lesion in the posterior fossa.
Cereballitis, viral cereballitis comes into play. So infectious has to be ruled out initially, at least from our perspective, I would say. And the other one will be any congenital malformations, any structural lesions, though it's very acute though, but still, I believe we should rule it out.
Yeah. So yeah, these are good thoughts, and actually we also included in our differentials. So we included it could be just acute cerebellar ataxia, it could be episodic ataxia, toxic exposure, labyrinthitis, could be migraine syndromes, could be, as you said, tumors in the posterior fossa, especially intracranial hemorrhage. It could be some like infectious process, could be demyelinating disorders, and also genetic disorders as well. So
Real-
for the work,
question.
yeah.
In the absence of any other like cutaneous findings and so forth, would we ever jump to a deficit in thiamine, not dissimilar from an adult alcoholic?
I mean, for this case, we didn't include that in our differentials, but maybe we can ask the attendings for their opinions.
Thiamine for this age would be pretty rare, possibly a vitamin E deficiency, and rarely B12 in this age. But it's definitely something to think of, especially if your first several differentials don't pan out.
Thank you.
Thank you, Dr. Williams. So for this patient's workup, again, later I'm going to go into more detail. But at that time, CBC, CMP, CRP, they were all unremarkable. We checked for the infections. Initially, RSV flu, they were negative. UDS was negative. We also did a respiratory virus panel, which included a lot of viruses. They were all negative, except EBV, it was seropositive. And then, interestingly, coronavirus OC43, it was positive, but this is obviously different from the 19. And actually, the test was repeated after a couple days, and it was negative. So here I have the initial MRI, which was done when the patient first presented with ataxia when she was 23 months old. So hopefully you can see the video. So anyone can tell me if they see any abnormalities? This is the T2 flare, by the way. Does anyone see anything?
Can you replay it?
Yeah, I can, but actually. Yeah, so actually it was non-specific. There is some like hyper-intense T2 and flare signal in the posterior parietal white matter, but those could be related to terminal zone of myelination, so it was non-specific. And when she again presented, the MRI brain was repeated in December 2018. So this is the repeat MRI. You will see, but it was again non-specific. There was no evidence of mass. The T2 flare signal changes in the posterior parietal white matter. It was stable. So after the MRI, of course, LP was done, and these are the CSF labs. Glucose was 57, protein 27, nucleated cells, it was 0, and at the time, the blood glucose was like around 1/10. We also checked oligocanal bands, IgG index, both in the CSF and serum. They were unremarkable. So the next slide, actually, I'm gonna show like an algorithmic approach to acute ataxia in children. I know it's very small. I'm gonna summarize briefly. but it's really a good table. So on the left side of the screen is actually showing some differential diagnosis for the chronic ataxia, which should include like congenital abnormalities in the posterior fossa, as you already mentioned, degenerative CNS disease, and also like metabolic disorders and demyelinating disorders, like MS. On the right side of the page is the approach to acute ataxia. So we look for any trauma to head and neck, which can cause, of course, like intracranial hemorrhage, cerebellar contusion, vertebrobasilar artery dissection, and of course, like concussion. If there is no history of trauma, we also look for signs of increased ICP, which can be seen in posterior fossa tumors. We look for focal neurological findings and also for fever. Again, we can see those in like cerebellar abscess, meningitis, brainstem encephalitis. And on the image, if we see demyelinating lesions, that can be seen in ADEM as well. If there is no history of fever, no focal neurological findings, we always need to look for toxic exposure. On the exam, if there's any like weakness, areflexia, we should include GBS in our differentials. And like always look for vertigo. If there's any history of acute otitis media, it can also be seen in labyrinthitis. And if there's nothing else, like if everything is negative, it could be just acute cerebellar ataxia after a viral infection. So this is our patient's timeline. First, when she presented in December 2017, she was 23 months of age. She presented with ataxia. She had a staring episode which lasted about 2 minutes. She had fever, URI symptoms, and also diarrhea. MRI was done with the basic labs at that time. MRI, as we already saw, it was non-specific. And actually, patients' symptoms improved the next day. So she was diagnosed with acute cerebellar ataxia, and then she was discharged with a neurology follow-up. And after about a year, in December 2018, she was admitted to PICU after having a seizure. It was GTC. And again, she had this like ataxia. She was found to have neck stiffness and high fevers. So for suspected meningitis, she was started on antibiotics, also with acyclovir. CT head was done, it was negative. LP showed just for nucleated cells, glucose was 62 and protein 24. And again, the repeat MRI, as again we saw, it was non-specific. It didn't show any leptomeningeal enhancement. Long-term EEG was done, which was normal. It didn't show any epileptiform activity. Toxicology, they were on board, but there was no concern for any ingestion at that time. And eventually CSF culture came back negative, and patient received IVIG for ataxia because we were thinking it could be some like autoimmune process, and was discharged to inpatient rehab after PICU stay. In December 2018, the workup included some other tests as well, like serum amino acids, urine organic acids, serum lactic acid, ammonia, to rule out metabolic disorders, and everything was unremarkable. Genetics, they were on board. We also sent encephalopathy autoimmune panel from serum and CSF. They were both negative. And then after a month, this was in January 2019, patient actually started having this like persistent myoclonic movements. And that was the time we were also concerned about this like opsoclonus myoclonus syndrome. And the workup for neuroblastoma was initiated. Urine HVA, VMA, they were checked and it was negative. Again, for the protocol, we checked MRI, chest, abdomen, pelvis with the cervical, thoracic, and lumbar spine, and they were all negative. Hemonc, rheumatology, they were on board. Given the history, family history of Huntington disease and chorea, we checked this like Huntington disease repeat analysis and also copper ceruloplasmin. They were all unremarkable. So after a month, patient was discharged from the hospital. And actually, she was taken to UFM for a second opinion, and she stayed there for about 2 weeks. In addition to all the workup already done, she had a chromosomal microarray and also this custom gene panel with sequencing and deletion duplication analysis. But these results also, they were like uncertain significance. And finally, in April 2019, that was the time patients started having opsoclonus, and this like opsoclonus myclonus syndrome diagnosis was made. Patient was already on steroids, and after 3 days steroid course, we started her on rituximab. So this was our final diagnosis for this patient. But actually, at the end, I'm gonna talk about like what happened later. But just to talk about opsoclonus myclonus syndrome, it's like a rare disease, incidence of 0.18 cases per million per year. It is characterized by opsoclonus with diffuse or focal body myoclonus. It could be with or without ataxia and other cerebellar signs. It's also called like dancing eyes and feet. It can affect both adults and children. For children, mean age is like 1.5 to 2 years. Some studies showed higher prevalence in girls, and usually it's paraneoplastic in origin, but it can also result from viral infections, metabolic disorders, intracranial hemorrhages, or tumors. So this is a really nice video showing opsoclonus. So here you see these like spontaneous arrhythmic saccades. They occur in all directions.
It's also important to note that they're conjugate, so there's no.
Yeah, they're conjugate. Yeah, correct.
Yeah.
So this was the opsoclonus. For the pathophysiology, it's believed to be autoimmune, but there also there are studies showing these antibodies that react with CNS antigens, some of them directed against cerebellar Purkinje cells. And also there are some other studies demonstrating these antibodies against the surface of cerebellar granular neurons. The other presumed pathophysiology, genetic susceptibility, and also chemokine abnormalities. So there was one report indicating chemokine receptor ligand CCL21. It was elevated in patients in pediatric OMS, and actually they were returning to normal levels after they're treated with steroids. So for the clinical features, patients can present with ataxia, falls. It can progress over days to weeks. Viral prodrome is common. They can have myoclonus, tremor, and hypotonia can develop later. Opsoclonus may not be present at initial evaluation. It can occur after weeks or months. This was also the case for our patient. We can see behavioral changes and also sleep abnormalities. These are common. For neuroblastoma, symptoms precede the diagnosis of neuroblastoma in approximately 1/2 of the patients, and the clinical course, it can fluctuate in severity, and they might have like a prolonged course. So this is a study, observational study, which was done by Pranzatelli, and it was published in 2017. So here in this figure, there's like 10 presenting neurological signs of OMS in children, and we see the order of the appearance of these like clinical findings. Lower the rank, earlier the sign. So we might see these like staggering irritability, falling body jerks before opsoclonus. And for neuroblastoma, neuroblastoma is the most common malignancy associated with OMS. Actually, 50% of children with OMS, they have underlying neuroblastoma. And in turn, approximately 2% of children with neuroblastoma, they develop later paraneoplastic OMS. Like neuroblastoma is more common in boys, but associated OMS actually is more common in girls, as we already mentioned before. Again, non-paraneoplastic OMS could be infectious in origin. So it could be seen after hepatitis C, Lyme disease, EBV, HIV, mycoplasma, rotavirus, and even for the idiopathic cases, it's presumed that there's like a post-viral origin. So for the workup, it's a clinical diagnosis, and there is no specific paraneoplastic biomarkers. But we know that there are like studies showing these OMS, paraneoplastic OMS patients, they have higher frequency of other paraneoplastic antibodies, including anti-HU, than healthy controls. But these antibody screening is not clinically useful. Of course, we need to do basic lab work to exclude other differential diagnoses like toxic metabolic encephalopathy, liver disease. If these are all negative, we also need to check for infections, including HIV. And of course, we need to analyze the CSF. EEG in cases of OMS also reported to be normal. And for our patient also, it was normal. For neuroblastoma, as we already said, OMS patients, half of them, they can have neuroblastoma. So we need to screen for it. And then the screening protocol, we need to check for chest, abdomen, pelvic MRI. We need to measure urinary VMA and HVA. And if those results are negative, then we can do MIBG scan. And if all negative, then actually we need to repeat the evaluation after several months. For the management in pediatric OMS, there are no controlled studies, but the used like therapies is the steroids combined with immunotherapy, which are plasma exchange, IVIG, cyclophosphamide, and also rituximab is used. We need to address the underlying neuroblastoma with surgery maybe, and then of course we need to involve rehab. Again, for the treatment regimens, we can use prednisone with like a prolonged taper over several months, or we can use pulse dexamethasone therapy. ACTH can be used, and there are studies showing that rituximab added to other immunotherapies actually effective. This is a study, again, was done by Pranzatelli. It was published in Pediatric Neurology in 2017. So in this study, it's like an observational retrospective study. They included 19 children with OMS with or without neuroblastoma, and they looked for the biomarkers for neuroinflammation. 9 patients was in the group of this triple therapy with pulse dexamethasone, IVIG, and rituximab. And then 10 patients received just like dexamethasone alone or with IVIG. And then they scored the motor severity using the validated OMS evaluation scale. So the results showed actually this triple therapy was associated with a 69% reduction in the motor severity score, and it was statistically significant. It was also showing these like lower B cell frequencies in CSF and blood. And these patients who received triple therapy, their positive inflammatory markers also dropped like 87%. So that was a good study showing that actually using triple therapy was effective. For the prognosis, if patients have a monophasic course, it's more favorable than chronic relapsing course, of course. And the motor symptoms, actually, they might improve or resolve in approximately 60% of patients during initial treatment. But neurological relapses may occur during steroid withdrawal or with intercurrent infections. Approximately 60 to 80% of patients, they have residual behavioral abnormalities or psychomotor retardation. And we mentioned that like more intense immunosuppression is better outcomes, but for neuropsychiatric disability, actually studies couldn't show like better improvement with more intense treatment. And regarding neuroblastoma, the survival prognosis of children with OMS secondary to neuroblastoma is better than neuroblastoma without OMS. So that was my presentation. If there's any question, I can answer. Oh, and by the way, for our patient, so the genetic